For several years now, Medicare Advantage plans have grown in popularity due to their zero premiums and lots of free perks. When the original program was birthed back in 2003, insurance companies promised Medicare that they would deliver better care at a better price, and Medicare decided to give them a blank check to do it. Well, in the last 20 years, we know that the insurance companies have made billions and billions of dollars, but they have not delivered on either of their promises. So beginning in 2026, the party is over. And that's why millions of people that are on Advantage plans are going to get a notice just like this, and you could be one of them. Here's what it says. Your current Advantage plan ends on December 31, 2025. This means you'll only be covered by original Medicare starting January 1. So to avoid a gap in your current Advantage plan coverage, you'll need to enroll into a new Medicare plan. Start here by viewing your new options, put your zip code in, and now you're going to have to find a new plan. So in this video, I'm going to explain why this is happening and the impact that it's going to have on those that are covered by Advantage plans. All right, I want to begin by really looking just at the kind of the big picture, the landscape of what's going on as we move into the 2026 enrollment period. As you can see, we're titling this The Impact on Advantage Plan Holders. And just want to let you know, this is really just a sampling of what's going on in the market. We are using 4 different companies here that are in the Advantage space. As you can see, one of these well over 8 million enrollees, one almost 3 million, then almost 2 million. This would be a regional carrier here at 145,000. And so again, this list could go on and on as we talk about the many people involved in Advantage plans. There's some 34 million people. Now, not everyone is going to be affected adversely, but many are. So let's go through this. So you can see MA just simply stands for Medicare Advantage. That's when there's a plan that doesn't have a prescription drug component attached. MAPD means it includes inpatient, outpatient, and a Part D plan as part of that package. All right. And then you can see what this particular company here with over 8 million people, we know that there's going to be about 600,000 people from that one company that will be impacted. And I'll show you the impact of that here in just a minute. Again, 150,000 by these 2 carriers, 55,000 here from a regional carrier. And right now they say somewhere between 1.5 million to 2 million people are going to be adversely impacted by these changes going on within the Advantage plans. Okay, so it's a huge impact. Now, let's talk about really the details of what's causing this to happen. Why are we seeing this at this particular point in time? Because frankly, ever since Medicare Advantage began, it has been growing and growing, but now we're going to see actually a decline. And so what's causing the excess? Number one, a tremendous amount of regulatory pressures that exist. Of course, we have a new administration, and it's not like they're not in favor of Advantage plans, but they are seeing that there has been a tremendous amount of abuse within the system, a lot of upcoding. Of course, you've seen in the press some of the lawsuits that surround this, as some of these Advantage companies really have taken advantage of this blank check that's been given to them. And so we have this regulatory pressure. We know that there's issues going on now, right, with a hospital Part A trust fund. Obviously, some of the money comes from that to be able to fund Medicare Advantage plans. They're also putting pressure on companies to change some of their practices within pre-authorizations. We know they're going to have to start streamlining that and to reduce those. And so these companies are starting to see the impact that now they're going to have some accountability, from the government. So that's number one. Number two, medical loss ratios is a huge deal. In fact, I'd even add to that really medical inflation. Medical loss ratio simply means that there's so much money that they take in now is exceeding their margins that they're looking for. These companies have the legal right to make a 15% margin, but when they have excessive claims and excessive use and high use, then they're not making that margin, and so their medical loss ratios have really increased. Now, what's interesting about this is a couple things. We know that during COVID, a lot of people delayed getting procedures, and then in 2023 that started up again, and so insurance companies saw a lot of additional claims because of that. But the new phenomenon is kind of interesting. In days past, what people would do as they were approaching retirement, they would get some of their major procedures covered while they're still working under a group plan. The main 4 would be cataract surgery, rotator cuff surgery, hip and knee replacements. So again, people would get those while why they're still working. But now that's changed as company plans have increased the deductible, the max out of pocket. Now people are waiting until they go on Medicare to do that. And so as soon as they're on Medicare, they begin to have these procedures. And again, that's what's affecting the medical loss ratios that these companies are experiencing. Number three would be unprofitable markets. In the past, the name of the game has been just get anyone and everyone to enroll, and they tried to expand. And now they're looking at the data of some of these markets, and they're saying we are losing money on these markets. Now, we actually saw this starting to happen last year. We saw many plans being terminated because of this. And so, again, they're identifying these markets that are just simply not profitable for them, and they're pulling out of those markets, or at least reducing their exposure in those markets. Number four, profits over patients. And sad, this is kind of the name of the game. And some of these even leadership within the company are starting to promote this, to their stockholders, and they're saying, hey, we're going to start taking make sure our plans are profitable versus the patients. Okay, and so and that's why you'll see these adjustments. And you and I will look at this and say, hey, that's wrong. Now, by the way, most of you watching this would be like me. We're capitalists. We understand that companies have to make a profit, but sometimes it's at the cost of the care to the patient, and that really is the problem with that particular philosophy. And so they're starting to focus on this more. And also, I think a lot of this has to do with a lot of private equity money now in the Medicare Advantage space. And there's a lot of pressure for these companies to perform. And then also challenges of capitation. This is a huge issue. Remember, Medicare Advantage is not a fee-for-service plan as the original Medicare system was. A provider provided a service, and they got a certain fee for that particular service. That's not the way Medicare Advantage plans are funded. It is called capitation. And so what happens is when someone enrolls into an Advantage plan, now they're under the umbrella of an Advantage company, and that Advantage company is responsible for them, for their medical expenses. And they get a flat rate for that. And right now it's in the neighborhood of about $1,000 on average. If someone has chronic needs, it could be higher. Medicaid could be higher. But the point is they get a flat fee. And so, of course, they want to make a profit, so they try to hold on to as much money of that they're going to get because they're not going to get any more. And so they have to manage that. And that's why they have the right to have pre-authorizations and different tools that they have to actually manage people's care. And so there are challenges within that system today. It's simply not working in some areas, and that's why some hospitals are pulling out of Advantage completely, and doctors and specialists pulling out completely. Why? Because that rate they're paid by these companies, it's just simply too low. All right, and so that would be an issue. And then lastly, this is probably the last on my list. It certainly is not the least important. So what happened when the Inflation Reduction Act was passed? It had a great impact upon Part D plans. Those are self-administered prescriptions that we take, on our own. Those are covered by Part D plans. Either it's a standalone drug plan, if you have a Medicare supplemental plan, or it's embedded within your Advantage plan. And so I think of the 70 million people on Medicare today, I think 55 million of those actually have a Part D plan. And so what happened with the Inflation Reduction Act is they said that the maximum expense for any insulin in formulary would be $35 a month. Part D plans had to start covering required immunizations, vaccinations, which primarily was the shingle shot that they had to add to their formulary at no cost to the patient. And also then what happened is beginning in January 1 of this year, 2025, they put a cap on out-of-pocket spending by the Medicare beneficiary. And that cap right now is $2,000. Okay? $2,000, that's the most. So I have clients right now that are on medications that are literally $13,000 to $15,000 a month. I had one the other day, a lady that was on Stelara. Her prescription was over $33,000 a month. She won't spend anything near that. Why? Because all drug plans today, as long as the medication you're on is in formulary, it has a cap now of $2,000. Now, next year, that's going to go up $100, so it'll be at $2,100. So in the past, prior to 1/1 of this year, the government took on a greater responsibility for these catastrophic costs on medications. Well, they transferred that risk from themselves to the insurance company. And so when they did that by establishing this cap, it looks good for the consumer, But what happened is insurance companies are not going to lose money, so they've had to figure out a way to be able to make this work. And so they're trying to make it work. How are they going to do that? By reducing formularies, by increasing premiums, all right? And so the whole point is this is a big deal. Yes, you and I look at it and say, well, that's really good. But the problem is the government no longer is assuming as much of that risk as they did in days past, and now it's on the insurance company. So again, that's putting pressure for them to have to exit some markets. Okay, so these are the primary causes that we're seeing this disruption. All right, lastly, I'm going to talk about the consequences. In other words, what impact is this going to have upon people that are enrolled in Advantage plans or will be enrolled in those this year? So here's the consequences. And again, these are not in order of importance. I just want to make sure you know what to expect as a possibility. Number one, we're going to see a tremendous amount of plan terminations. You saw that on our sheet as we just began the video. Plans are going to be termed. People are going to get notices like I read. That is going to happen, and it could happen anywhere from 1.5 million to 2 million people are going to be termed. Now, the reason this occurs, folks, is because Advantage plans are only written for 1 calendar year. That's it. It's actually a contract between Medicare, the insurance company, and you, the enrollee. And so what happens, the government told them originally these only had to be for 1 year at a time. And so they have the ability to increase the benefits or decrease the benefits. They can pull the plan if they want to, as we're going to see here. It's not profitable, so the plan's no longer available because, again, it's just a 1 year contract. That's it. Number two, consequence, service area reductions. And what this means is that these plans are regional or local, and they're going to start reducing those, meaning a company may have maybe 4 plans in an area, and now they're going to have 1, or maybe they have 2 this year, and they're going to have 0. So, I mean, they're pulling out of areas where it's just simply not profitable. That's a service area reduction. So, geographically, people are going to be affected. They may pull a plan out of a particular zip code or a county, sometimes even a whole state. All right, so that's a service area reduction, and we're going to see a lot of that this year. The many plans are being crosswalked, and this is something a lot of Medicare consumers are not aware of. But what happens if you're on an Advantage plan, and let's say that plan is termed, it's no longer going to be available, what happens, the insurance company has the right from Medicare to automatically crosswalk you or enroll you into a similar plan. Now, that similar plan is obviously not the same plan, it's a different plan. And so what people have to do is they have to be paying attention if they get crosswalked to make sure that their doctors are still in network, that their medications are still properly covered, that they're happy with the copays and coinsurance and all the details financially on that plan. But again, this is going to happen. One of the consequences, there will be lots of people crosswalked in automatically into other plans. Number 4, we're also going to see lower Part B givebacks. Now, a Part B giveback is certainly not in every plan anyways, okay, but some of you have them. And what that means is you're on a certain Medicare Advantage plan where the Medicare Advantage plan is taking some of its capitation, some of that predetermined rate they get every month, and they actually give you a credit back on your Part B. Which means if you're on Social Security, it causes your check to go up. If you're not on Social Security check, then it causes your Part B premium bill to actually go down. That's a Part B give back. And so again, that's the insurance company, Advantage company, just giving you some money back. Now, normally when they offer that, they're doing it not because they're trying to be benevolent, it's because they probably decrease the benefits in that plan in some way. We see this happening a lot with people that have the VA or TRICARE insurance, which is retired military, or they're retired from the federal government. They already have drug coverage from VA, TRICARE, or the federal government, FEHB benefits. And so what they do is they actually will get what we call an MA-only plan. So they don't have a prescription drug built in because they get their drugs elsewhere. And so that insurance company is willing to give them part of that money back that they get towards their Part B premiums. And so that exists right now. Again, not all plans, but many of them do. But we're going to see less and less of that as we move into 2026. Now, I'm not saying we're not going to see any of that. I'm just going to say there will be an impact for sure on the givebacks. Next, we're going to see some increasing premiums and deductibles. Now, right now in this market, there's about 4,300 Medicare Advantage plans across the country. They say the average market has about 40 plans that they're able to look at, 40 to choose from. And so what we find in the Advantage market, about 2 out of every 3 plans is actually a 0 premium plan. no premium whatsoever. And by the way, we're going to continue to see some zero premium plans, but some plans are going to add a premium. We're actually going to see some premiums. We see them now, but I think we're going to see a little bit more of that as we move into 2026. And that's why I would encourage you, be sure when your annual notice of change comes to look at the details going on within that plan for 2026. You want to make that comparison. Again, we're going to see some of the zeros moving up. And then when it comes to deductibles, as a general rule, the majority of Advantage plans did not carry a deductible. Many times, not only did they not have a medical deductible, they didn't have a prescription Part D deductible either. They just had copays. That is going to change. So we're going to see some medical deductibles. And that just simply means that some of the medical services that you get, you may have to pay a deductible first. That could be a hospitalization or an outpatient surgery. And when a company is going to charge you a deductible, they'll let you know what services or then that deductible would be applied to. All right. So secondly, I can assure you we're going to see a lot of the drug plans now are going to charge that deductible that Medicare allows. Next year, the Part D deductible, that's allowable, no more than this, would be $615 for the whole year. Many medications we take are deductible exempt. But most of your brand name, Tier 3, Tier 4, Tier 5, are going to be subject to the deductible. So again, if you're taking those brand name medications, that's going to be a change. You're probably going to have to satisfy that Medicare D deductible. So again, we'll see changes there. And then next, rising copays and coinsurance. In the past, the carriers tried to have a few services where there's a zero copay. I think we'll see less and less of that. We'll probably see some copays that were zero. Maybe now it's going to be $5 or $10. Maybe last year, your specialist copay was $25. It may be $50 this year. Hospital copays, $300 to $400. Probably see an increase in that as well. But point is, be sure to pay attention to that. Now, another thing we're starting to see is that historically, Advantage plans have been pretty much a copay type system. There were a few items that were co-insurance, maybe chemotherapy, durable medical equipment, but I think we're going to see more of the services instead of having a flat copay where you're going to pay 20% or maybe 10% of that bill that's allowed by Medicare. All right. And then less provider choices. This is sadly a reality. One of the issues with Advantage plans in the past and now, I think this is even going to be worse. It's a limited choices. Why? Because two things. We either have HMOs or we have PPO plans. And so that just simply means that the doctors and the specialists and the hospitals that serve you, they actually are enter into a contract with that Advantage company at a certain rate that they'll be reimbursed for their services. And if they don't like that reimbursement rate, they don't take that plan. That means they're no longer going to be a network. And so we're seeing hospitals, less and less hospitals taking an Advantage plan, less doctors. Now, I'm not saying there's not still plenty to choose from. I'm just saying there definitely will be less because the companies are not going to be able to pay them as much, and that's going to impact how many choices that you have. Now, listen, on this one here, more HMOs and less PPOs, I think we're still going to see a fair amount of PPO plans, okay? But in the past, that was really the great majority, unless it was like a dual eligible plan. But this year, I think we're going to see a lot of those plans, PPOs, not in some of the markets at all. So the whole point is many people like PPO plans because they have the right to go out of the network. On an HMO, you have to stay within your network unless it's an emergency or an urgent care situation. So what I think we'll see this year is that when we do have an HMO plan, we'll probably also have what's called a POS option, and that stands for point of service, point of service. So you'll be able to go out of your network on an HMO plan, some of these, but it will cost you more to do that. So again, you'll be restricted then to the providers within if indeed you want to save money. All right, so that's going to happen. And then decreased formularies, and this will occur for sure. These formularies are the list of medications that are covered by the plan. When we look at it, let's say just kind of a decent formulary, we're going to have about 2,500 medications that will be covered by that plan. Kind of one that's better than that would be 3,000 meds, and the best is going to be about 3,500 meds. And so when we look at different drug plans, that's what we're looking at. We're looking at the formulary. Why? Because we want our medications to be covered by that plan, because then it falls underneath underneath that $2,000 cap. And so we want to make sure our meds are covered. And so as the companies are taking more and more of the risk on for these expensive meds, we're going to see those formularies decrease in size. Now they have to cover certain meds. There's rules for that, but they don't have to cover all meds. And the least amount of meds they can cover, the better for them financially. So rest assured, this is going to happen for sure. And then dwindling perks. Now, when I talk about perks, I'm just talking about some of the freebies that are often offered and certainly advertised. Talking about Advantage plans, that would be typically a gym membership. I don't think those are going away, but gym membership would be a perk. Another one would be a dental allowance. I never refer to a Medicare Advantage as a dental plan because it's typically not like a normal dental plan. It's a dental allowance. And they may give you $1,000 a year, and sometimes that's only for preventive services. They don't cover other services. Sometimes it may be $1,500 a year, and it's combined, preventive plus comprehensive. And one of the issues is most of these plans work because they have a network of providers, and sometimes it can be difficult to find a dentist that's within the network. Now, some of the plans, they'll just give you a flat amount of benefit. They'll say we'll cover $1,000 a year, go where you want, and if the plan doesn't take, the doctor doesn't take the plan, the dentist doesn't take the plan, then you can pay out of pocket and then apply for a medical reimbursement. In other words, they'll pay you back up to that limit. And all I'm trying to teach you is that you want to make sure that you know how the perks work, because again, these are starting to dwindle. I don't think they're going away. I'm just saying they're definitely going to be different. Also, a perk would be vision. And some of the plans will give you a basic eye exam once a year. They'll also give you a credit towards eyewear. Many of them are about $100, $150 every other year towards contacts or eyeglasses. And then hearing aids. Some of them will cover hearing aids, and that's a great benefit. It's still going to be limited. They don't cover all hearing aids. They may cover certain ones. You may have a copay and hearing aids that you get to choose from. And the whole issue here is just be sure as we see those perks, they're not going to be as strong as what they once were. I think that 2023 was really the great. 2024 was the strongest, greatest year for perks, and then they began to be minimized this year, and certainly even going to be more minimized as we move into 2026. Okay, so the whole point is we are going to see some things change. Okay, as I said in my introduction, the party is over, and some of you are going to be affected by that. And so I would encourage you, do your due diligence. Take the time to read through your annual notice of change. You should have it no later than October 1. It's simply a packet that comes to you from your present insurance company listing for you the changes they're making. They'll say you're on our plan in 2025. Here's what we're doing in 2026. That's when you'll learn whether the plan was termed. That's where you'll learn whether the plan was crosswalked. And so just make sure you do your due diligence, see if that plan is still going to work for you. And if you're curious if there's something better for you, contact us. We'd love to take the time and look and actually see what's available in your market. We write for almost all of the carriers, so we have exposure to those plans. And so we take the time to make sure docs are covered, hospitals are covered, and you're really happy with that plan. Okay, so read over your ANOC. I want to make sure you know that people can begin to discuss plans, us, agents, from October 1 to October 15th, but we can do no enrollments. We can't do any enrollments until on the 15th of October, and then that goes through December 7th. So you have about 7 weeks where you can make these changes. And so again, take your time. Don't be pressured. A lot of times agents come across as though this is the latest and greatest thing since sliced bread. Probably not so, but they still are good plans, and you want to find something that is really going to serve your needs well, one that you're comfortable with the max out of pocket, one that your docs and hospitals are going to be covered. And then I'll close out with this. We're seeing really a trend, and I think this is a positive trend, as people look at the financial exposure for Medicare Advantage plans, they realize that if they had a serious health event, they could reach that max out of pocket. And these max out of pockets are going to be higher next year. We can see some as high as $10,000, some $5,000, some $7,000 if you had a serious illness. And if you don't have that money saved away to pay that, what you may want to consider doing is get additional insurance. These are called hospital indemnity plans, copay protection plans, and critical illness plans. And so the way they work is with a hospital indemnity plan or a copay protection plan. Those are similar. It means that you can get, at a very low premium, some additional coverage to cover your hospital copays, ambulance rides, as well as ER costs. And so you get an insurance policy for that. And again, they're very inexpensive so that you don't have to pay for those hospital copays. And then we get a critical illness plan for people that if they had a heart attack, a stroke, or got diagnosed with cancer, then they would get a lump sum payment, because typically those health issues, heart attack, strokes, and cancer especially, cause people to hit their max out of pocket. So if you don't have that money saved up, then it may be a very good idea to get some coverage for that. So if you did have some real expensive situation occur, you have some money from an insurance company to help offset those expenses. Again, those are called critical illness plans. All right, so anything that we can do at this time of the year, please reach out to us. We'll give you the time. We're not going to apply any pressure. Just so you know, we also write supplemental plans as well as Advantage plans, drug plans, so we write them all. And so we'll do whatever we can to make sure that you're on the plan that is best for you for 2026 and have confidence in that decision. Thanks so much.